In 2008, I was diagnosed with MS. I was over in the Dayton area. My primary care physician looked at me and said, I think you have MS. I said, I think so too. And she said, I got 5 patients here. You're my 5th patient that has MS. And I've sent every last one of them to Columbus because I really like the doctors there. I was supposed to see a certain doctor who, when I called in August, I was told the first appointment she had open was November. But they did say, we got this new guy coming next week. And if you wouldn't mind seeing him and help us break him in, we could set you up with an appointment with him immediately. And that's how I came to be a patient of Dr. Boster's. I haven't left him since that time. He can't get rid of me. And I think at times he'd like to. We have a great relationship. But we are very fortunate to have gotten him here from... I'll say the word. Okay, I know I'm in Columbus, but he came to us from the state of Michigan. Okay, I said it. Don't throw anything at me. And he's down here in Columbus now. He's here with Ohio Health. He's the head of the program with a fancy title, which I don't remember. But I'd really like to introduce, as our closing act here, Dr. Aaron Boster. Many of you know him as your patient, as your physician, as your friend, as your confidant. Many of you don't, so I think you'll find this enjoyable. Dr. Boster.
Howdy! Oh, wait. So Laura was a little off. I was born and raised in Columbus, Ohio, lived here until I was 18, told my parents I would leave and never come back. I was wrong. And they want me to use a microphone. Like Stuart, I've never been told I needed one, but let's try it. Love is in the air. No, I'm not going to sing. All right, so tonight we're going to talk a little bit about new concepts in MS. Several years ago, I was asked to give a lecture to the National MS Society. And when I got close to the lecture, they said, we're going to give you 5 minutes, and we would like you to really focus on explaining the pathophysiology of multiple sclerosis. So 5 minutes to explain the pathophysiology of MS. So I took the challenge, and I decided that I would explain it using cartoons. And I've been using cartoons to teach MS ever since. So let's talk a little bit about what MS is. Multiple sclerosis at its core involves the immune system, we believe. Immune cells are these little white blood cells that live inside our bone marrow, and they come out of the bone marrow, and they're young and dumb, they don't know what they want to do, and they go to school immediately, and that's at T-Cell University up in the thymus. So T-Cell University is a very weird college. It's free to get in if you're an immune cell, and there's only one class. Can you identify a self cell compared to a foreign invader? And that's the only class. And if you pass the class, there's only one profession, that's soldier. And then you run around the human body checking things out. Now, what happens if you fail the class? Well, they take you out back and murder you. That's true. So it's kind of a strange school. It's easy to get in, but you want to do really well. All the cells that graduate from T-Cell University should be able to identify self versus non-self. Autoimmunity is a term that we use when there's been an error in judgment with our immune cells. And some of those immune cells went to T-Cell University, failed the class, and they didn't take them out back and murder them. And these mistaken cells identify a part of the human body, your body, as an invader, as a foreign virus, bacteria, something like that. And every time that immune cell does its tour of duty and sees that part of you, it attacks it, thinking it's doing the right thing. If the autoimmune attack occurs in the joint, we call that rheumatoid arthritis. That's an autoimmune condition. And if it happens in the pancreas, we call that type 1 diabetes. Multiple sclerosis is an autoimmune condition where the immune system mistakenly attacks the holiest of holies, the brain, the supercomputer that runs the body, and the superhighway, the spinal cord that takes all that information to and fro. And so my first cartoon is to share that really MS is a situation immunologically of friendly fire. Today we heard a little bit about so-called invisible symptoms. Invisible symptoms are not talked about enough. Invisible symptoms erode our quality of life and make us feel isolated and embarrassed. And it's something that we need to be discussing. The list there, which I'm going to read to you, is generated from a survey. They took 1,000 multiple sclerosis patients and 500 caregivers, and they asked them a bunch of questions. And I think it elucidates some of these invisible symptoms. Number one, half of the people, so 500 out of 1,000 respondents, felt limited because of depression and anxiety. And that is one of the most common invisible symptoms in MS. Now, Dr. Nicholas did an eloquent job of talking about the majority of MS patients being women, and women of childbearing potential. Men with MS in our culture are not oftentimes comfortable sharing that they feel depressed. It's a sign of weakness. And so I need to tell you that it's not a sign of weakness, and that depression erodes your life. And if you can share it with us, we can help you. 2/3 of respondents said that people around them didn't know they had MS because they couldn't see the symptoms. Think about that for a second. Think about you walking through your daily life and the people that you come in contact with, and you look so good, but you look so fine. And in reality, there's a lot going on. And so that's why this invisible concept is so very important. 40% of patients that filled out this survey shared they couldn't do their household chores because of fatigue. Now think about that for a second. How often you say, I'm tired, and someone says, oh yeah, me too. And so I try to explain it to spouses the best I can. Imagine that Monday you went to work, and Monday night you didn't go to bed. Tuesday, without sleep, you went back to work. Tuesday night you didn't go to bed. Come to my clinic on Wednesday, and that's how many of my patients feel when we talk about fatigue, and yet it's a so-called invisible symptom. One more example from the survey that really caught my attention. 1/3 of people that responded decided whether or not to leave the house based on their bathroom problems. They didn't leave their home for fear of wetting themselves. After the age of 3, it is not cool to pee your pants. And in our culture, it's terribly, terribly embarrassing, isn't it? And it saddens me that someone would be locked up at home for that. I got a pill for that ill. Invisible symptoms are something very important. Now, the title of my lecture was MS is like a leaky pool. And I'm going to do something that I haven't done before. I want to try to explain to you the newest model of multiple sclerosis using this leaky pool. There was an older model of MS that was developed by a guy named Dr. Lublin. And he's a great man. I call him a silverback. Stands up on stage and beats his chest and tells you how it's going to be. And that model has been largely replaced by a young gun, his mentee. A good friend of mine, Stephen Krieger, developed this leaky pool model, and I'm very in love with it. And so follow along. It sounds very different than the models that we were taught by Dr. Lublin, who's an amazing guy. Hi, Fred. So the first thing I want to show you here is that this is intended to look like a swimming pool. And this is the deep end, and over here is the shallow end. And then here's the water level. Now, the water level represents what we call the clinical threshold. What's that mean? Anything above the water level, the patient will experience symptoms. Anything below the water level, no symptoms. It's an easy concept. Now, the amount of water in the pool is called the functional reserve. The functional reserve is a very important concept in MS that we don't talk enough about. And if you're wondering what I mean by functional reserve, think back to when you were 18, or maybe 17. And it's Friday, and you finish school, and you feel good, and you work your part-time job, and you finish your part-time job, and you packed your clothes so you get changed and go out with your friends. And then you called your mom and said, Mom, I'm not going to be home right away. And you didn't go home. And you stayed out all night. And maybe you came home at 6 in the morning and took a quick shower and went back to your job. Remember? Saying it makes me tired now, right? We had a larger functional reserve when we were younger. As we age, naturally, the functional reserve shrinks. In the setting of multiple sclerosis, it shrinks way faster. And I'm going to come back to that point, but I want to show you something in the pool. The deep end has a larger functional reserve than the shallow end. The floor of the pool represents our nervous system. And this deep end, where there's the most functional reserve, is the top part of your brain. Those are called the hemispheres. And we know that for every one clinical attack, we can see 20 spots on your MRI, mostly in the supratentorium, mostly in the hemispheres, because there's a large functional reserve. Our brains can rewire and accommodate pretty well up here. Now the yellow area, there's less water, there's a smaller functional reserve. And that represents, in neurology, what we call eloquent area, an area of the brain where there's less work around, there's less functional reserve, and that's the brainstem, the infratentorium. Now, on the shallow end of the pool, over here, there's very, very little functional reserve. There's very little wiggle room, and that represents your spinal cord and your optic nerves. If you look at these stalagmites sticking up from the base of the pool, those represent activity. Activity is a new terminology in multiple sclerosis, which is very important. Activity is when the naughty autoreactive cell that made an error and thinks your brain's foreign crossed from the bloodstream into the brain and did what I just said. It attacked it, and it caused an area of inflammation. Now look at the pool. If this lesion, this stalagmite, does not cross the clinical threshold, you don't know it. You have no clinical symptoms. Right, by definition. You can see it on the MRI, but it's clinically silent. If the threshold is crossed, if that stalagmite goes up enough that it breaks through the water, that's a clinical attack. And so this model lets us talk about many, many things in multiple sclerosis. I'm going to call out a couple. On the right side of the screen, I've thrown up something that we sometimes refer to as highly active or aggressive multiple sclerosis. And what do you see? The water level is the same, but there's a bunch more spikes coming up, and many more of them across the surface. I want to teach you another term, and that's called breakthrough. If you are taking a disease-modifying therapy for a relapsing form of MS, and you have activity, that's breakthrough disease. That means the drug didn't work. That's the equivalent of an epileptologist giving someone who has seizures a drug to stop seizures, and then they have a seizure. It didn't work, right? And so that's breakthrough disease. I'm going to use the model to make a couple other points. This is an example of progressive disease state. In the setting of progressive disease state, I told you that the water levels fall and the functional reserves shrink. And this little blue arrow is intended to represent that. As the water levels drop, we uncover areas where there's been previous activity, even clinically silent activity. And as you uncover those areas, you manifest symptoms. That's called progression. And so we can do a lot of neat things with this model. Last night we were having pizza and beer at the Beer Barrel, which is a really cool place in Hilliard, Ohio. And we were using this model to talk about the future of multiple sclerosis. What's the future of therapeutics in MS? Well, we need three things. We need three kinds of drugs to beat this disease. We need an anti-inflammatory to make these spikes go away and not occur. Today, there are 15 FDA-approved MS therapies, 18 different formulations, and they're all anti-inflammatory agents. They all make those not show up. That's one type of medicine that we need. We need a second type of medicine. I told you that this is a leaky pool, so we need a plug to plug the leak. And we might refer to that as a neuroprotective agent. We don't have one of those yet. Many, many studies are ongoing in attempts at developing one. And lastly, another way to beat a leaky pool is to add water. If we could add water to the pool, we could raise the level. And there isn't a disease-modifying therapy like a remyelinating agent that does that. There is a symptomatic agent which helps us buttress heat sensitivity, and that's the last thing I'll explain with this model. When we talk about getting overheated and our body short circuits, what's happening is the water level's here, and you go outside in Ohio in August, and your water level drops because of heat. It uncovers leg weakness in this example. And when you cool your body back down, or there's actually a medicine that can help you do this, it raises that water level temporarily back up. So this is a new way of thinking and talking about multiple sclerosis. Dr. Krieger invented this to be used in a clinic setting with an individual patient. And he won't give me the computer program yet. He's being selfish. But I really like this, and I hope that it helps us understand ways of thinking about MS a little better. I'm going to not go through these slides, and I want to focus now on new concepts in MS treatment in specific. How many people here know what a meme is? Raise your hand. I didn't. I had no clue what a meme is. I thought a meme was a mispronunciation of some other word, and my wife laughed and corrected me that a meme is a thing. A meme is a picture with some words. And so I started to download internet pictures and make words, and I showed it to her, and she said, honey, you're not memeing correctly. So the rest of my talk is all memes that I made up the other day, and they're approved by my wife. She said I did okay. So I want to use them to talk about the history of MS therapeutics and the future of MS therapeutics. And I want to tell a story about the sins of our fathers. What do I mean by the sins of our fathers? The people that trained me remember when there were no therapies to treat MS. 1993, the very first therapy came out. And there was such a low production that there was a lottery to see if you might be able to get it. And going from nothing to something is a revolution. It's a transformation. And that's true. And for the next 15 years, we had what in hindsight were good, not great, mild to moderately effective therapies. And we became, as a community of MS treaters, very comfortable with those therapies. Turns out in hindsight that they're safe, or at least generally safe. Now, as you move forward in time, we have now brought to market several highly effective therapies that are quite genuinely better than what we had before from an efficacy standpoint, or at least that's my strong opinion. And my fathers are not readily adopting these therapies. And they still stand up in congresses and they talk about the value of the original drugs. And I think that's a travesty. I like to ask patients, God forbid this was breast cancer and not MS, is it okay if I use the fourth best drug available to treat you? I've asked hundreds and hundreds of patients that question, and I've always gotten the exact same answer. And I think that we need to move away from the sins of our fathers. Dr. Nicholas and I have been very involved in training the next generation of MSologists. Dr. Carrara will graduate in a week, and we're very proud of him as he goes out into the world and improves MS in North Carolina. He doesn't suffer from the sins of my fathers. He suffers from my sins. Poor guy. Now, in the era of 15 different treatments, we can now talk not about untreated MS, but about undertreated MS. And I ask the question, what's the similarity between untreated MS and undertreated MS? And the answer is the same thing. There's a lot of similarities. And I think that we need to right set or level set how we think about our therapies and our expectations for them. Because to take a therapy, to take an injection or a pill or an infusion, you're accepting a degree of risk. But if it's not working, you're not getting the benefit. And that's when I think we really need to critically think about what we're doing. Because what we find is if you don't respond to your therapy, you're going to get worse. And we shouldn't do that. Now, many of you know that I am a Trekkie. I have very, very fond memories of watching the original Star Trek with my father as a kid after we were done doing all our chores on Saturday. And I thought this was a perfect meme with Jean-Luc Picard, talking about subclinical disease activity. The other day, a very bright patient said to me, Aaron, I don't want to get an MRI this year. I said, why? She said, because I feel great. I'm doing super. And I said, that is exactly why we're going to get an MRI. If you're doing cruddy, I don't need to spend money on an MRI because you just told me you're not doing well. I can figure that out from our conversation by examining you. When you're feeling good and looking good, and I get an MRI that shows a couple new lesions, you're not going to do good. I am guilty of standing on a stage like this and saying to people, treat the patient, not the scan. Treat the patient, not the scan. Treat the human, don't look at the picture. And guess what? I was wrong. I apologize. I was wrong. It turns out that if your scan's evolving, give it 5 years and you will too. And so I understand why Jean-Luc was so upset by this meme. What if I told you that you didn't have to accept MS disability? What if a brave new world we could reset or change our goals in MS? If you ask an epileptologist, a seizure doctor, his or her goals, they'll very quickly say, no seizures. And if you ask a diabetes doctor his goals, he'll tell you about a hemoglobin A1C, or he'll talk about avoiding end organ damage. For fun, ask your MSologist their goals for you and watch them say, it's actually kind of funny to listen to. And we need to be very clear about our goals in MS. Before I tell you about the goals, we have to talk about breaking up, divorcing your therapy. I like to remind patients that you're not married to your disease-modifying therapy. You're dating it. And it's a constant reevaluation of the love that you have. So if your disease-modifying therapy treats you right, then we're going to keep on keeping on, and that's a wonderful relationship. But if your disease-modifying therapy is starting to misbehave, we might give them a warning once, maybe. Second time, we're done. I tell people, if you bring my daughter home late once, we're going to sit down and have a conversation. If you bring my daughter home late a second time, you'll never see me or her again. Now, mind you, my daughter's 8, but I'm getting ready emotionally for what's coming. Now, when do you break up with your therapy? If you're taking a drug and you have an attack, guess what? You have SAR. Something ain't right. It's not working. And that's my diagnosis I made up. SAR, something ain't right. It's a great diagnosis, and it tells me that the drug you're taking isn't doing what it is we want to be done. If you're on an MS medication and you are losing functionality, that's another case of SAR, and that's another conversation with an MS clinician that something's not going well despite you taking this therapy. That's breakthrough disease. I want to talk about that for a second, because some doctors naively think that MS can be explained by an attack, an MRI change, and change on exam, which is not true. I recently had a young man come in and say, Dr. Boster, you're about to examine me and you're going to tell me I'm okay, and I'm not okay. Really? What do you mean? He said, well, when I was in college, I played baseball. Okay. And I was good at it. Okay. And I decided that I was going to coach my 9-year-old daughter's softball team. Okay. So I went and got my daughter a glove and a softball. We went in the backyard, and I was pretty excited, and she was excited. And I got down, I showed her how to hold the ball, and I threw it to her, and she caught it in her mitt first time. I was very proud of her. And then she took the ball, and she threw it at me, and I put my hand up, and the ball hit me in my face. And I told her, honey, that's okay, don't worry about it. And I brushed it off and grabbed the ball. We made eye contact, and I threw it to my daughter, and she caught it. And then she threw it back, and it hit me in my face. He said, Dr. Boster, I can't catch a softball. Now, I don't keep softballs in my clinic. And is he having a functional loss? Heck yeah, he's having a functional loss. Would I pick it up on my fancy pants neuro exam? No, I wouldn't. So there's 2 points here. You got to tell me when something's happening, or I don't know. And when you tell me something's happening, I need to respond. Confirmed disability is the same thing. If I see your EDSS is changing, that's a conversation, particularly in early relapsing disease. I'm not okay with that. And if you hate your drug, that's not okay. I remember in the era of injections, I had purple injections, green injections, red injections, blue injections, but they're all shots. And if you were having trouble taking your shot, I just put on a cheerleading outfit and jumped up and down and said, you can do it, because I didn't have any other options to offer you. Well, guess what? It's a brave new world. We have all these medications, and they all have different side effect profiles and tolerability. And if you're ruining the quality of your life taking your medication, talk to us about that. Because if I keep your disease quiet, no relapses, and you don't have any new things on your MRI, and your exam's not changing, I'm not done yet. Do you see the hidden finger? That's the hidden finger of tolerability, which is all about quality of life. So if you're having trouble taking your drug, that's not a sign of weakness. That's a conversation. Say, Aaron, this kind of stinks, man. You got something else? Okay. Now, this is the target for MS. This is what we need to do. It's called NEDA. No evidence of disease activity. Or if you live in a Spanish-speaking country, it's NADA. No apparent disease activity. That's a joke, laugh. Thank you. And NEDA is like winning national championships. At the beginning of the season, 64 coaches gather around and they say, boys, and I've never played a team sport, but I assume this is, boys, they say, this year we're going to be dead middle. No, that's not what he says at all. He doesn't say, this year, young men, we're going to come in last. That's not what does he say? He says, this year we will be national championships, right? Every single coach tells every single team that they're all going to win national championships, which means that 63 coaches are lying. Well, not exactly. Not exactly. Because if you play your heart out and you come in second in the nation, you did pretty darn good. NEDA is a challenging thing to achieve, but it's what we need to shoot for. It means that over a period of time, you're not having an attack in relapsing MS, your MRI is not evolving, and your exam's not changing. And if you achieve NEDA, even for a year, 1 year of NEDA, the likelihood that your physical examination won't get worse in 7 years is 73%. If you can hold NEDA for 2 years, that likelihood of not having a change in your exam at 7 years later goes up to almost 80%. And so I like to think of NEDA as the sign in my dad's factory, days since last accident. 1, 2, 10, 13, 100. Oh, darn it, there's an accident. When that happened, my father didn't close the plant. They figured out what was wrong and they reset the clock. And I think that we should use NEDA in the exact same way. I'm going to leave you with a comment, a way that I think we need to think about MS. We heard Laura today talk about becoming engaged in your multiple sclerosis. I want you to conceptually think of MS as an unwanted passenger in your car. You can't get MS out of your car. It's not an option. But today, you have to make a decision. And the decision that you have to make is who drives your car. And I'm being serious. Because MS will be very happy to drive your car. But you won't like where MS drives you. So I have a different opinion. Now, I'm a Lowe's man. And if you like Home Depot, that's fine. But I know where everything is in Lowe's. And so I recommend that we go to Lowe's and we pick up a couple of key items. Item number 1, rope. Item number 2, duct tape. I like purple. You could use, they have all kinds of different colors now. And then I want you to buy a baseball bat, which is in season. I want you to go out to your car and open the car door, and I want you to hit MS in the head with a baseball bat. And I want you to keep hitting MS until it can't move very well. And then I want you to tie MS up. And then I want you to duct tape his mouth. And I want you to drag him into your trunk and close the trunk. And then I want you to sit in the driver's seat and turn on music. I recommend Paul's Boutique, circa 1983, Beastie Boys, but you pick your own music. And I want you to crank that up, and I want you to drive your car. Now, Stuart and Laura are desperately trying to get me off the stage, but I just want to leave a couple messages before I go. Number 1, if you have relapsing MS, the sooner you start on a medicine, the better it is for you. Number 2, if it's not working, don't keep doing it, please. Number 3, if you smoke, you speed up your disease. Now, you're an adult, you make your own decisions, but golly, that's something that we're trying so desperately to prevent. And exercise improves a multitude of things in MS, as we heard from our wonderful occupational and physical therapists. Lastly, keep in mind that low levels of vitamin D drive this disease faster, and so we like ourselves a little D3 action. Thank you very much for your attention.
Thank you. And so, like we did the first time, while we wait for the other 3 to come on up, like we did the first time, Sarah's going to be off to this side, I'm going to be off to this side. We're going to do this for about 30 minutes. Please remember also we have physical therapists and occupational therapists up there too, and we can get started.
Okay, I wasn't going to come up here and be part of this, but I thought this was my part that Stuart just said. That's okay. We're working this out. This teamwork thing is new for him. I think it's done pretty well tonight. So you guys have been a great audience so far, and I know you have some dynamite questions. I'm just going to clear off the stage. I hope you'll mix it up with PTOT and this expert and really challenge them. Ask them the questions they don't know the answers to. I'm counting on it, so go for it. You guys you want the mic out of your hand? right?
I have a question. Can I ask the therapist a question? Please? So my question to you guys is, if someone has a legitimate hitch in their giddy-up and you need to rehab them, you're going to see an opportunity for physical therapy. But what about the patient who doesn't need physical therapy but is having trouble becoming conditioned? What about the patient that goes to the gym and meets Biff, the personal trainer, and has a really, really bad experience because he doesn't understand heat sensitivity and motor fatigue and energy conservation? What can we do for those patients?
Well, the first thing I would do is first still go see a physical therapist, because we don't know how you're going to respond to exercise until we see you in the clinic. We don't know if 5 is your magical number, if 10 is your magical number, and then you need to know the symptoms and also how to progress yourself. Therapy doesn't last forever, so we need to give you education beyond simply a program. We need to teach you how do you take yourself to the next level. And beyond that, we need to get you hooked up with the resources in our clinic that we have, from occupational therapy, from speech therapy, from our social worker. So we might not see you for a long time for formal physical therapy, but we're still gonna help you and we're gonna get you hooked into the community.
What about a wellness program?
Well, that would be wonderful. But it's
So I can't prompt her any longer. Hey, will you tell us about the upcoming wellness program that Ohio Health is doing for MS patients?
I can, but it's full. So we're doing a wellness program at Ohio Health. It's going to be a 12-week program, twice a week, and I see someone giving me a stink eye because she doesn't know about it. And it's because it won't work with your work schedule, and I already knew that. But I'll talk to you soon. It's going to be group exercise twice a week for 12 weeks with education. And the hope is after this pilot program, it'll be available to many more people. Right now, it's a select group of people just because we have limited numbers. But stay tuned for more to come and more opportunities for you to participate.
So before I give the microphone to this first person, I have to ask Dr. Boster. Boster, are you finished asking questions?
Yes, sir.
Great. So I have a question too, and that is, do you have room for horses in your facility for hippotherapy?
No.
Do you recommend people do hippotherapy?
It depends on what your goal is.
Balance.
Horseback riding, balance. There's no research out there that's necessarily clinically proven.
Can we let them know what it is? And it's not about hippopotamuses?
Oh, it's horseback riding. Horseback riding. So it's used a lot in pediatrics. I haven't seen any clinical trials in the MS adult population. It's used a lot, like I said, in pediatrics. But I think if you enjoy it, then it's a great route to go if it's going to keep you active.
First question.
On vitamin D, is there an amount that's too much to take?
Yes.
Oh.
Next question. No, I'm joking. So we have found a magical number of 50. It looks like if your vitamin D level is below 50, you have an increased risk of developing multiple sclerosis. And if you already have MS, a level below 50 tends to drive the disease faster. And so we shoot for above 50. You can become toxic on vitamin D, and I've had a couple patients do that, trying to do the best for themselves, and they kind of went a little overboard. And so instead of saying this is the number that you need to take every day, we check levels and treat to the level. And so tell your MSologist and tell your MS practitioner, hey, what's my vitamin D? You haven't checked it? Why not?
Yeah, so if we're not locals and we're traveling into the clinic and we are with the therapy, so that's usually an extended time frame. It's just not one visit, if I'm right. But once you do your evaluation, do you send the information? Like I would go to Dr. Boster as my MS specialist. Would I go to you as my occupational MS specialist, and you would transfer that information to a local therapist, or do we work?
That's exactly what happens. There's occasionally times that we may talk with the patient and family and decide, boy, there's really not any good neuro experts in your area. But more often than not, we're really just kind of trying to suggest a plan and then sending that plan to the outlying location and letting them know, hey, here's what we're finding, here's what we want to be worked on, what we would do as if we were going to keep them with us.
And I think to that effect, we do things a little bit differently in our clinic. So I have quite a few patients who've driven 2 hours to come see me. They come see me once every 3 weeks, and I block my schedule and I spend 90 minutes with them. So they have more time to spend with me, but and their end, you really have to hold up your end of the bargain because I'm not going to be barking orders at you weekly. So sometimes I do send a little phone call and tell them I'm going to know if they didn't do their exercises. But we also structure it that way, and then you could see me anytime that you're in the clinic with Dr. Boster or Dr. Nicholas.
We have a question on this side.
Could Emily speak a little bit about swallowing?
I can. So a speech therapist could do an evaluation to look at your swallowing ability. I can't speak as much to it because I'm not a speech therapist, but they can do an evaluation and then provide strategies. There's also imaging that they can do as well to look at if you're having any what they call aspiration, or if the food or drink is going down the wrong way. So they can provide strategies and look at safety with swallowing. Does that answer your question?
Well, could I have a definition of aspiration?
Yeah, so it's just if you're, if when you're eating or drinking, the food is going down toward your lungs, essentially. Oh yeah, go ahead.
If I can piggyback off what Emily shared, there's 3 things that scare the heck out of me. And those 3 things can lead to an MS patient dying. So I find that to be really serious. The 3 things are a decubitus ulcer, so a bed sore, which seeds the bone and causes an infection. The second thing is a urinary tract infection that backs up into the bloodstream and causes urosepsis. And the third thing is aspiration pneumonia from this problem that you're talking about. So we take this very, very seriously. If you're having problems swallowing, or your spouse says that you're having problems swallowing, or you're sputtering or coughing, or eating or drinking with you is a bit challenging, you're obligated to tell us that. And at least at our center, we'll bring a speech pathologist into the room that day in clinic to do a test to figure it out. Because we can modify what you eat or drink, or modify the way you eat and drink and make it safe. And that's a big deal, guys. That's a real big deal. Thank you.
Oh, I just had a question about the group exercises. When is that going to start?
So we are piloting this. It's very new for us. And we're piloting it. We're going to start this in August. We're going to run it for a couple months. And if we can demonstrate that it works, and we think we can, then we're going to do it every 3 months. And so tune in. We're very excited to offer this to many, many more people in Greater Ohio. But we have to pilot it first to prove that it's going to be okay. Tune in very soon.
Next question.
Yes. This was a question for, forgot her name now.
Her.
What does she look like?
The social worker.
Sarah.
Sarah. What's her contact number? Thank you.
So if you call 614-533-5500, that's 614-533-5500, you'll get the Interdisciplinary MS Center, and you can ask for the social worker, or you can ask for Sarah Grimm by name.
Yeah, I found out that going to physical therapy is a great thing, but the equipment is not, it's kind of unilateral. It's for anybody for any disability. But I found out that by making my own MS-related equipment that worked for me, seems to work really well in keeping up, and I do keep up with what I'm supposed to be doing. But I've talked to a lot of people that have no idea that they can do that.
Absolutely. I find that my patients are the most resourceful people, so I often ask them what they're doing. And I get ideas from them because you don't have a gym at your house, and it's expensive to get one in your house. So you have to use what you got, and patients are the most resourceful. So I love that you said that.
Hello. I'll hold it.
Hold your wand. It's okay.
My question is for you 3 ladies. Physical therapy, I always thought about it as something that you got when you got an injury on your job. And so my question is, for people with MS, do I just tell my doctor, look, I want to get some physical therapy, and they will refer me over to you? Dr. Boster, are you my doctor?
The answer to your question is yes. Tell your provider that you want to see a therapist. Tell your provider that you like to walk a little better. Tell your provider that you want expert help with your balance or with your gait. And they'll serve up some physical therapy or occupational therapy as deemed appropriate. Absolutely.
Also, is there like, I heard about the group physical therapy. I think that's awesome. And as soon as I'm not in the next one, but as soon as I can get in one, I want to be in one. And also, are you thinking about like some weight training, weightlifting exercise?
Absolutely. So the group fitness will involve cardiovascular training, it'll involve weights, it'll involve balance, and it'll involve exercise. Education. That's all exercise. But yeah, we're very excited, and stay tuned. I'll ask him for your name and I'll put you on my backup list for upcoming programs. And then about the physical therapy, so not all therapy and occupational therapy, not all therapy is created equal. So make sure that you're asking the question of who you are going to see. If you tore your ACL or you tore your rotator cuff, you don't want to see me. That's not what I do. Could I treat you? Yes. Would I treat you at the level of an orthopedic physical therapist? No. What I do all day long is neuro rehab. So if you have achy knees, don't come see me. If you're having problems with your walking, if you're having problems with your balance, your mobility, your endurance, your falling, all those things, that's when you want to seek out neuro. And it is worth making the drive to see a neurotherapist.
Any questions down there? You know, we have these experts up here on this platform. I would think that... Do what?
Bueller. Anybody?
Right here.
I was wondering, I belong to the McConnell, but I don't feel like I really get as much out of it as I would if I knew what I was doing. Are you going to incorporate some program with them? Maybe?
That's where the program is going to be. Woo! So, you know, I'm talking a lot about the program, and I wish I could say it was open to everyone right now. It's not. But the thought is when we do see progress, because if you exercise for 12 weeks, you're going to see progress. We'll be able to have the resources to do it on a larger scale. If you feel like you're not getting benefit from what you're currently doing, it's time to shake it up. We don't ever want you to just kind of coast.
Work with the therapists that are whoever the exercise people are at the McConnell already so that they can better help?
Absolutely.
Or know what because I don't really know either, so I don't know what to tell them.
We definitely will. They're going to have more education, but from that skilled guidance, working one-on-one with a trainer might not give you to the level that you're looking for without a skilled set of eyes to look at you and develop a program for you.
Does massage therapy have a place in MS treatment as opening up like nerve pathways or just simply stress reduction?
Massage therapy is awesome. I used to have my massage therapist on speed dial. And there's not very good research looking at the neuroimmunologic or immunologic benefits of massage. So I don't think we know the answer. What I will tell you is many of my patients get through their day because of their massage therapist. And many of the problems that we see in MS can be improved, at least symptomatically, with massage. For example, if your leg's weak and so you lift it like this all the time, this hip ain't doing so hot. And it's going to cramp and spasm and hurt like the dickens, and a massage therapist can get in there and open that up. And so I strongly encourage massage therapy. And by the way, if your insurance doesn't cover it, you can ask for a prescription and submit it with your taxes and have a tax write-off because it's being used medically. And that's a very appropriate use of that therapy.
You talked a lot about vitamin D. Is there an underlying cause why these individuals have vitamin D deficiency?
Yes. So the question is, you talked a lot about vitamin D. Why is it so low? It's low because we live in Ohio. And so for 7 months out of the year, there's no sun to be seen. And for the months that we do have sun, we're taught to avoid it. I was very excited when my wife brought home these crazy swimming shirts that my kids can put on that are SPF like 7 million and the sun can't penetrate it. I'm like, that's a great shirt. But we get vitamin D from the sun. And so Ohioans run around with very low levels of vitamin D. If we had a clinic in Sao Paulo, Brazil, we probably wouldn't be having this conversation. And we'd all be bronzed gods and goddesses. But in Ohio, we're kind of pasty. And so a lot of times we have to supplement vitamin D by taking a supplement of some sort.
You know, I'm from Florida, and I had a count.
Rub it in, buddy.
I had a count one time of a 9 from vitamin D.
Yep. And we see numbers like that not infrequently. It's the rare patient that doesn't need to supplement at least a little bit.
So whenever I was carrying my first child, I'd gone to physical therapy for massage for sciatica. There's your foo-foo, like Valentine's Day special massage, and then there's your medical massage. So is it just a matter of calling around, or do we do the massage through physical therapy?
So like many, many things, like doctors, like physical and occupational therapists, there's different kinds of massage therapists. You got to interview your massage therapist. You got to tell them what's going on and what you need. And I had to go through a couple massage therapists before I found my Lenora. My Lenora was the only gal that could get in there and help me. And so it took 3 tries before I stumbled on her. Oh, wait, I'm sorry. Lauren's going to add one more comment.
So related to that, you said you were pregnant when you were having that pain. So in that instance, I would actually recommend that you seek out a women's health specialist, because that's all they do every day, the same thing. And your back pain, your hip pain was likely related to the extra weight you were carrying from your pregnancy and then lax ligaments.
Right.
So.
Well, that's what I was wondering, because this wasn't an outside agency. This was on hospital property. So it was through a trained physical therapist, I'm assuming?
Correct. Now, a physical therapist is not going to give you a 60-minute massage. What we're going to do is release tight muscles in specific areas and then give you exercises to strengthen the muscles that aren't working and why you're overcompensating with other ones. So yes, we will do massage, but it's not going to be, your aromatherapy, turn off the lights and go to sleep on me.
How does a yoga program fit into this exercise program?
Amazingly well. Amazingly well. Yoga and Tai Chi in particular are slow movements with stretching. They involve core stability. They're outstanding. I've had many patients use yoga and have amazing results where they're now doing stuff like this and they weren't able to before. I adore yoga for our patients. And in fact, we routinely give out DVDs for yoga for MS. So next time you're there, let me give you one.
I feel like I'm hogging the mic. I'm going to see if Em wants to talk about that too.
I would definitely agree with what Dr. Boster said. I think you have to consider bone health. That's one thing that I've been doing a lot of research about. So with the low vitamin D levels, just be aware of your bone health, and there are particular poses that you may want to avoid if you do have bone loss. So if you have osteopenia or osteoporosis, you just want to be aware of that, and a physical therapist could help guide you in particular poses maybe to avoid, just to protect your back. But otherwise, I think it's wonderful for balance. There's great ways that we can modify even in therapy or in a group yoga class where you could use support as needed for safety, but wonderful results.
Yeah, I've been doing reading and studying on vitamin D, and one thing that hasn't been mentioned is how much sunlight is effective. And what I've been reading is only 30 minutes a day is effective for getting your daily amount of sunlight for vitamin D. And you might not need a lot of SPF if you're only in the sun, direct sun, 30 minutes a day. So like you mentioned, it's counterproductive sometimes to say, stay out of the sun, stay out of the sun. It's creating vitamin D deficiency and wearing SPF all the time.
So it's a complex issue because skin cancer kills people, and skin cancer is directly related to sun exposure. And so there are some legitimate reasons why doctors may encourage you to avoid high sun exposure. The rubber meets the road when I check the blood level. And so if you get 30 minutes of glorious sun a day and your level goes above 50, I'll give you a hug. But if it doesn't, I'm going to give you a hug and some vitamin D.
In addition to testing for vitamin D, do you also test for vitamin B12? And what do you recommend?
So B12 deficiency is not related to multiple sclerosis at all. And supplementing B12 outside of a deficiency is not something that I recommend. We do check B12 when we meet new patients, and if it's low, we supplement it, because low levels of vitamin B12 over time can create neuropathy, meaning your feet get numb, and you and I are going to think it's from your MS, and it's not. It can create cognitive problems, and we'll think that's from your MS, and it's not. And so it also creates tremendous fatigue, which I would think was from your MS and not. So I do think when we look at an MS patient, we can't be naive and just think about MS. We have to think about a human being, and that includes thinking about B12. Excellent point. Thank you.
I was wondering if there's any research concerning acupuncture in MS, because there's an acupuncture school right down the street.
Mm-hmm. So if there's a therapy or a medicine or a treatment that I wasn't taught about in my medical school, allopathic medical school, I was taught to call that complementary. That's a complementary therapy because I wasn't taught about it, which is kind of silly, right? So in the United States, acupuncture, as an example, is considered complementary. If you go to China, it's been used as a mainstay for therapy for 1,000 years. And so complementary therapy doesn't mean it doesn't work, although oftentimes complementary therapy hasn't been studied in a rigorous fashion here in the United States. So I have 3 rules for complementary therapy. Rule number 1, it can't be too expensive. So if you have to take out a second mortgage on your house to take your complementary therapy, that's a case of SAR. Something ain't right with that. Now the second rule is it can't be dangerous. Acupuncture, I don't find to be dangerous. There are certain complementary therapies that are, in fact, dangerous. And so that's not okay. And the third thing is, I can't condone a complementary therapy instead of something that I think works. So I want to do it in addition to something that I think works. And so your example is a beautiful example. Acupuncture won't be cost prohibitive. It's not dangerous. And if you're doing the stuff that we've talked about today, I adore the idea of you doing acupuncture. And if it helps you, I want you to come tell me about it so that I can turn around and tell everyone else about it. And that would be very cool.
Yes, Dr. Boster. 2003, I lost my vision through optic neuritis from MS. Is there any type of way to get my vision back?
No. So I wish I could tell you something different, but I can't. And I don't sell false hope. And so that's terrible. And the damage done to the optic nerve, and I showed you that there's very low functional reserve, at this far out is permanent. And so here's how I would like us to talk about it. You can't see very well out of one of your eyes. And that's a reminder why you need to fight back, because you want to keep the other one. That's a reminder why we want you to be physically fit, to not smoke cigarettes, to supplement your vitamin D, in relapsing disease states to take an effective disease-modifying therapy. We use that terrible thing that happened to you as a reminder for why we fight so hard. I wish to God there was a way that I could give you your optic nerve back, but we're not that good yet. Our kung fu's not that strong.
Question. What can you tell those that are interested in knowing about stem cell research?
So recently there was an exciting publication by a Canadian guy who did some stem cell research and published the results. And in fact, I was involved in some stem cell research before I left the place that I worked that I don't talk about as much anymore. Stem cell research is intrinsically sexy. It kind of sounds cool. I'm going to take out these cells and I'm going to insert them in your body and you're going to regrow everything that's going to be perfect. That's not true. Number one, stem cell therapy is not a cure for multiple sclerosis, right? Number two, there's a very, very significant morbidity and mortality. Those are $3 words for people get hurt and they die. And so I cannot condone a stem cell transplant outside of a controlled clinical research trial. There are places you can go in the world like Mexico and India and Chicago, and if you pay them money, they'll swap out your bone marrow. Or at least that's what they'll tell you they do. That's a very scary thing to do outside of a controlled experience. Now, I do think that there's a role for stem cell therapy, but it's still evolving. We're not there yet. And so tune in. It's an exciting field of study. In very rapidly worsening patients, I'm talking about a young MS patient who is having attack after attack after attack, and they're burning through the MS medicines. That's the archetype patient in whom we might consider highly, highly aggressive therapy, such as stem cell transplant.
Next question. 2 more questions.
Do it.
3 more.
Was this the Canadian chemotherapy stem cell?
So yes, it was. So let me explain how stem cells work, all right? So step 1 is you need to get a hold of some pluripotent stem cells that haven't evolved to do anything yet. One of the easiest ways to do that is to take them out of your own body, because you got some, all right? Sometimes you get them from someone else's body, but in an allopathic stem cell transplant, we take them out of your body, and then we put them on ice. Step 2 is we murder you. So we give you literally lethal doses of chemotherapy, which would ablate your immune system, and a common cold would kill you. But before you die, we give you back your stem cells, and we hope that they take and they rebuild an immune system that's not so naughty and autoreactive. So when you heard about the chemotherapy portion, that's required because we have to kill every single cell in your immune system or it won't work. It's called a conditioning regimen, and that's what we're doing in a stem cell transplant.
I'm sorry. And we had a couple of deaths with this?
So in the specific trial that she's talking about, Mark Friedman was the international PI. There was 24 patients or 23 patients studied, and there was 1 death.
Okay, thank you.
Yes, hi. I would like to know, regarding the wellness program, you say stay tuned. Is that through the email registration for this program?
So we do a lot of pilot programs. We're always trying to figure out different angles to try to help people with multiple sclerosis. And so as you come to clinic, as you check out our tweets, as you look at our Facebook page, as you interface with our therapists and our social workers and feel the love that we're trying to bring you, we'll update you about this over time. Oh, she wants to know my MS page. I didn't pay her to say that. So if you want to follow us on Twitter, oh look, it's right there, at Ohio Health MS. The Facebook page is facebook.com/Ohio Health MS, and the Instagram is Ohio Health MS. There's a trend there. So check us out. Brett, have you signed up for my Twitter account yet? Are you sure? I'm going to check after this program.
Going back to stem cells 1 minute. How is a stem cell therapy transplant different than a Lemtrada infusion?
That's a very high-level question. Thank you for asking. There's a therapy out called alemtuzumab. The trade name is Lemtrada, and it is a highly effective MS therapy. It's not a stem cell transplant, but it has a couple similarities, if you'll excuse that expression. When you take alemtuzumab, Lemtrada, it kills all of your adult lymphocytes. So all the white blood cells I was talking about, they got all kinds of different names. There's neutrophils and eosinophils and basophils and lymphocytes. And the lymphocytes have a life cycle. They're babies, pluripotent stem cells, and over time they grow and do stuff and then they die. And alemtuzumab, codenamed Lemtrada, kills the adult lymphocytes, knocks it down to a level where if you look at a laboratory, it looks like you have HIV. And it allows your stem cells to repopulate and grow back different. Interestingly, MS patients have a paucity of regulatory cells, immune cells that get everyone to calm down and relax and behave. And when you take alemtuzumab and the cell lines grow back, the amount, number, and activity of the regulatory cells comes back bigger. And so you can see how you may draw a parallel between alemtuzumab and a stem cell transplant, but they're very, very different. And although mechanistically they have similarities, and efficacy-wise they might have similarities, it's 2 very different endeavors. But thank you for pointing that out. That's a really astute observation. Any other questions?
Yes. I heard about this center called Ohio Health, and how are they different than other MS centers?
Now, technically, I didn't hire him to say that, but I did hire him to come and do this program, so thank you.
You're welcome.
So I decided to be an MS doctor when I was 12. Some of you heard this story. I decided to be an MS doctor, not because my uncle had MS, but because of his particular event, I'm a third-generation American. I grew up in a small, tight-knit family, and I watched my uncle deteriorate as a child. And that was something that my family had to accept. But that wasn't what made me decide to be an MS doctor. I decided to be an MS doctor because one day, my mother and my grandmother were crying out of frustration because they couldn't reach their doctor. And they were scared, and they didn't know who to turn to. And so I told my mom, I'm going to learn to do it better. At age 12, I had no earthly idea what I was telling her. I didn't know that I was going to be bald and have 2 kids before I finished my training. I didn't know that I would move back to Columbus after having said I never would. But I did know that no family should be treated that way. And I have a very, very clear vision of how I want MS families cared for. And I've been working my entire career in an attempt at realizing that vision. I've been at Ohio Health now for about 1.5 years, and I've never been more proud, and I've never had more fun taking care of patients than I have since we started. We do something a bit different. Our mantra is interdisciplinary, comprehensive, longitudinal, patient and family-focused care. That's our goal. We put the patient at the center, and we move heaven and earth around them. And so I'll give you a very quick example of what that feels like in clinic. When you come to see us in clinic, you have to come a half an hour earlier than you're supposed to. That's no fun. Why? It's because we have to do the MS Olympics. There are validated measures that are very, very sensitive to pick up MS disability. The PEG test that we have you do, and the walking thing we have you do, and the annoying low contrast vision that we have you do, and then the math test. Whew! Those tests are highly accurate and reliable to pick up disability, and we do them before you see your clinician. Then we stick you in a room. In one visit, you're going to see your MSologist, your doctor, who will spend a half an hour with you. 3 months later, you're going to see your nurse practitioner, who will spend 45. The only problem with my nurse practitioner is everyone likes them more, but since I control the clinic, I can force you to still see me. And that's not where the visit ends, that's where the visit starts. Because we then, on a case-by-case basis, can activate a neuro-PT to come in the room, a neuro-OT to come in the room, a speech pathologist to evaluate thinking memory or swallowing, a clinical trial coordinator to share with you what's new and what clinical trial opportunities may exist, a social worker to help coordinate care or help you grieve or help you identify resources in your hometown. We can bring an infusion specialist to come in and explain to you what the heck's going on with trying to get yourself infused. And we can bring a billing specialist in to sit with you and explain and decode the complexities of the bill that you received. We can bring a registered dietitian to sit down with you and talk about nutrition. So I spend a half an hour with you, and you may be there for 4 more hours depending on your needs. We brought the wheelchair clinic to us so that you didn't have to go there. The clinic is 200 feet from the front entrance, and I mandated that we have free valet parking because that's only appropriate, and it's not appropriate to make you walk a distance. And if you are taking a therapy that's infused via IV, our 12-bed infusion suite, which is rather gorgeous, is literally in our clinic. So this is a very, very concerted attempt at realizing a vision of mine that I've had since I was a very little kid. And increasingly we're getting there, and it is so exciting. Thanks for asking that question, Stuart.
Thank you. We're finished.
Thank you, Stuart and Jill, for putting this together and getting us out tonight. I would like to make one observation about the Ohio Health MS team. And I haven't told them this yet, but what I would like their new motto to be is, we treat the person, not the MS. Because when they look at us, they know, they see us as people and not just a disease. It's been a great program. I hope your brains aren't feeling like they're going to explode, because there was tons of material, lots of good stuff here. I hope you walk out of here feeling empowered. That was our theme for the evening, to empower you. We did not compare slide decks, and I'm watching going the similarities like, whoa, we all nailed the same points, I think. Learn, be active, get involved. Don't just accept that this is the way your MS is going to be, because it doesn't have to be, and there's many things you can do. I have packs of M&Ms again with the I Conquer MS logo and the website on it.
Thank you, thank you, thank you, thank you, thank you. Thank you, everybody. Hey, you know, I want to thank everybody, including Laura. She did a great job tonight. Let's give her a round of applause. All right? And, you know, I have to thank all of you all for coming here, because we can't do programs unless you're here for us to do these programs. So I'm going to thank all of you for coming tonight. All right? And listen, we gave you seminar evaluation forms. Please get those filled out. Please write it down. If we have enough of the same type, we can easily do that for you, okay? So please make sure that we know about this. And again, everybody, thank you very much. And thanks to Ohio Health for getting us here.